Good morning, everybody, and thank you very much for the opportunity to be here at the 13th Interest and to be in this lovely city of Accra in the beautiful country of Ghana. I want to first greet Your Excellency, the First Lady of Ghana. I'd like to also recognize the presence of Honorable Minister of Health, the co-chairs of the meeting, the high table, and ladies and gentlemen. I also want to put a shout out to people living with HIV and just say that they are the stalwarts of the epidemic. They're the ones who can talk to us about the lived epidemic, the lived experience, and they're the ones who actually are at the forefront of fighting to end AIDS as we know it. There's almost 37 million people living with HIV in the world now. There's more and more people living with HIV in the world now because people are surviving. And that's good news. But it's also bad news because it means that people are still acquiring HIV. So these numbers increasing are the result of survival as well as new infections. And I think this is why a conference like this stops to remind us and see how, as Professor Katabiro was saying, how we can end the epidemic. The epidemic is still predominantly in Eastern and Southern Africa. Out of the 37 million people, about 20 million of them are in Eastern and Southern Africa, and about 6 million are in Western Central Africa. As far as the number of new infections, and this is really the thing that continues to worry all of us, it's about 5,000 every day. There's about almost 1 million in Eastern and Southern Africa, and about almost 400,000 in Western Central Africa. And there's 180,000 children that acquired HIV in 2017. The one thing I also wanted to mention is that the data that we have is 2017 data because 2018 data will actually be released on June 25th. It takes time to get the data validated and agreed upon. So what we have, the most recent data, UNAIDS, is 2017. You're able to push it forward? There you go. Thank you. Thank you. The number of deaths, there's good news on this because this is the first time we have less than 1 million people dying from HIV. In 2017, it was 940,000. It's very easy for that number to go back to over 1 million because of new infections and issues related to adherence, and I'm sure a lot of that will be discussed. Most of the deaths, again, just like most of new infections, came from Eastern and Southern Africa, and about just a bit over 250,000 were from this region. Globally, or rather generally, there's been a reduction in new infections in the region. In Eastern and Southern Africa, between 2000 and 2017, that is the way UNAIDS, that's how we measure it, there's been a 30% decline in new infections since 2000. That's 17 years. That's a long time to only have made 30% progress. And that's really the reason that the work on prevention becomes so important, as the Minister of Health was saying. And in Western Central Africa, there's been 8% decline, again, just indicating the amount of work that is still needed to stop new infections. As far as deaths, there's been more progress there. There's been a 42% reduction in deaths in Eastern and Southern Africa, and in Western Central Africa, 24%. This is testament to the rolling out of test and treat, as well as other interventions to help people living with HIV survive, as well as to stop new infections. But I think you'll agree that we need to accelerate the reductions in mortality even more. This is a bit of a busy slide, so let me just explain it. It's about putting the last mile first, and more people are talking about we need to understand where the real obstacle is at the end, and we should begin with that end in mind and not the beginning, because if we do not know how to get to the end, at the end, it means that we will not actually meet our goals. So if we look at the source of new infections, globally, about 47%, and those are the numbers that I've put in red there, about 47 globally is due to key populations. Key populations remain important in the epidemic. In all settings, Eastern and Southern Africa, they contribute about 17% of new infections. In Western Central Africa, they contribute about 40%. And then, just for comparison, in Western and say Western Europe, Central Europe, and North America, they make up about 90%. And the reason for these variations, it has to do with the intensity of the epidemic. In Eastern and Southern Africa, where the epidemic is way, way more generalized, then the contribution of the key populations may not be as high. It also has to do with the fact that we don't really have very good data among key populations, and that continues to be an area of concern if we really need to understand how to end the epidemic. And that's what we mean by putting the last mile first. Okay, I think this requires someone with the technological know-how. Oh, there, I think I got it. Yeah, thank you. Sorry about that. As far as progress in prevention, just getting a bit granular, in Eastern and Southern Africa, South Africa continues to be the largest, continues to have the largest number of new infections, which is about 270,000 in 2017, followed by Mozambique. So South Africa, that translates to almost 1,000 people a day. It's about 790-something people a day. And those are huge numbers. Fortunately, South Africa also has a very aggressive program, and I think they're making some progress, followed by Mozambique, Tanzania, and you can see the others. Now, I want you to watch this. So what I'm going to do is I'm going to keep that scale the same and see what happens when you put in Western Central Africa. Okay, let's do it like this. Can you just help me push the slides if you can, if you guys can? Okay, I got it. But just please, just push if I get stuck. So this is using the same scale. This is the epidemic in Western Central Africa. So moving from numbers of 270,000 new infections in South Africa versus the highest number that we have in this region, which is Cote d'Ivoire. So basically, just to demonstrate the significance of the epidemic, if you were to put the West Africa in the context of the chart that I was just showing, West Africa would come after South Africa, Mozambique, Tanzania, Uganda, Zambia, and Zimbabwe, and Malawi. So really just shows you the magnitude of the difference between the two regions. I wanted to say something about Nigeria, because there's been some progress. As I mentioned in this slide, the data I have presented here excludes Nigeria. And I wanted to talk about that and explain why. It's because Nigeria has recently, and I'm sure there's people in this room who are quite conversant with this, has just recently conducted the largest probably AIDS impact survey that has ever been done anywhere. So the data are still just being processed, but it's anticipated there's 1.9 million people living with HIV in Nigeria. Prevalence is about 1.4%. It used to be thought to be about 2.8%, so it's about half what it was initially thought, and about 1 million are on treatment. I wanted to also share in terms of progress in prevention. This is an important, important information. There's a global HIV Prevention Coalition, and I think if your countries are not yet active in it, and if you're not, or if you yourselves are interested in prevention and you're not engaged in it, I'd really encourage you to join this movement. It's co-chaired. It was launched in 2017. It's co-chaired by UNAIDS and UNFPA, and it has a very strong partnership. And the objective is to basically try and really handle HIV prevention, because we all can agree that we are not making the kind of progress in HIV prevention, and by that I'm talking about primary prevention, as we would like to. And just to share with you a bit more as to who the partners are. Sorry about that. It's, as I mentioned, it's co-chaired by UNAIDS and UNFPA. It comprises of the ministers of health from the 25 highest burden countries. Among the members are Global Fund, PEPFAR, Africa Union, and many others that you can see here. There's a website there, HIV Prevention Coalition at UNAIDS.org. So please go on there, find out about it, and engage in that conversation regarding HIV prevention. They just held their meeting the other last week in Nairobi, and among the things that they were talking about is, is where countries are. There's some countries that are staying still, and they are listed there. So it's, hello? Okay. Okay, thanks. I think we're having technical difficulties. So I'll just keep going. Countries staying in place, for example, these are countries that have not really made that much progress in terms of primary prevention, i.e. stopping new infections. Botswana, for example, Angola, Ghana, I'm sure we'll talk to that, Cote d'Ivoire, and so on. There's some countries that are considered walking. There's countries that are considered jogging. They're starting to gain traction. And then there's 3 countries that are considered running, which is Eswatini, Uganda, congratulations, and Zimbabwe. But no country has scored. No country is on track to reduce new infections by 75% since 2010. So I think it goes to show that we do have a long way to go when it comes to HIV prevention. The other thing that the organizers have done, can you put the next one, please? Is trying to ask whether did we get this wrong? Did we misunderstand the target? And it's really not the case. What happened is that the target is perfectly fine, the implementation is not so good. There's something really not working well with this. So, for example, the fast track model, which is what the targets were set up on, assumed that 90% of the key populations would be covered, but presently only 20 to 50% are covered. Assumed that there would be 6 billion condoms distributed by 2020, but this is not happening. Assumed that 3 million people would be on PrEP, but that's not the case. And assumed that there'd be a doubling of the funding, but this is not the case. So there was nothing wrong with the target. It's really more an issue of something with the prevention. If you move me to the next slide, please. And I really want to draw people's attention to this because the Prevention Coalition has put together a 10-point approach that would help countries move forward more seriously in terms of prevention. For example, just being able to understand the epidemic better, the first point. The second point being around revising the targets and making sure targets are accurate. Number 3, strengthening the leadership and all the other things listed there. And especially number 10, accountability. Who in the country is accountable for HIV prevention? I think when it comes to who in the country is accountable for HIV treatment, that's pretty clear. But when it comes to HIV prevention, it's not always very clear. And I think what we are finding, the drawbacks that we have in HIV prevention is that the programs are not really grounded, they're not really strong, and they do not have the political courage that is often needed. This is an example of what's going on in Botswana, and the key thing here is to manage the ecosystem so that the objectives are being achieved through the full results chain. Do you need to come and do something? And the other issue that we wanted to raise is about condom distribution, and I'll just give you just walk you through this. So the blue bars are showing you the total needs needed in a country. The yellow bars are showing you the target, and the green ones are showing you the actual distribution. So if you look at a country like Botswana on the far right, even though it's making the most progress, you can see that there's really insufficient condom distribution all across, but in this, and in Botswana, for example, it's only about half as much as that is needed. I'm not going to talk about this, but just to make the point, and therefore use of condoms as for HIV prevention is not anywhere near where it should be. But there's been good news. There's good news on male circumcision, voluntary medical male circumcision, there's been a rebound, and in fact, there's been a lot of progress. Countries like Uganda, Tanzania have made a lot of progress. And in fact, if Uganda keeps the rate of voluntary male medical circumcision, the country will be able to get to its goal of reaching 75% reduction in new infections. So as far as treatment is concerned, and I'll go quickly, the 1990 strategy, which we know about, the targets for 1990 are in 2020, so it means next year. As far as where we are globally, 75% of people living with HIV worldwide know they have HIV. 79% of those are on treatment, and 81% of those are virally suppressed. But in Eastern and Southern Africa, 81% of people living with HIV know they have HIV. 81% of those are virally suppressed, and 79% of those, 81% of those are on treatment, and 79% are virally suppressed. And lastly, Western Central Africa, 48% of people living with HIV know they have HIV, which means 52% don't. 83% are on treatment, and 73% are virally suppressed. So clearly the issue in Western Central Africa is helping people learn their HIV status so that they can get on treatment. Western Central Africa is able to put people on treatment, but I think it's having a challenge finding them. And it will be very interesting to hear from the colleagues regarding these findings. The other way to look at this is to look at instead of looking at those who know and those who and all that, is say of all people living with HIV, what is the situation? So globally, as I mentioned, 75% of all people living with HIV know they have it. 59% of all those people living with HIV, not whether they've only been tested, are on treatment, and 47% of all people living with HIV are virally suppressed. And these are the figures for Eastern Southern Africa, and these are the figures for Western Central Africa. And you have to look at this with worry, because it means that 29% of people living with HIV in Western Central Africa are not virally suppressed. It's not very good for the rest of the world, but it's certainly very worrying about Western Central Africa. And that is why there's been a lot of effort to accelerate services, to accelerate domestic strengthen health systems, address issues around user fees and so on. Just to make the point that it really is possible to end HIV and to provide services better, but unfortunately the interventions are not yet layered enough to be able to achieve those goals. The issue of TB remains to be a concern. I think more and more people living with TB are getting treatment, but not at the level that they need. In other words, both HIV treatment and TB drugs. As far as pediatric HIV, this is where we are, and we've got a long way to go before we can achieve that goal for children. This is because we are missing half the children when it comes to HIV testing as recommended by WHO, which is in 8 weeks after birth. And for that reason, many children are not able to acquire to get treatment. And if you look, you can see 52% of children living with HIV were on treatment, compared to 59% of the adults. But really, the fact that there's less children than adults getting treatment must be a cause for worry. And therefore, there's less and less viral suppression among children. As far as financing the response, there's a flatlining. I think we all know about donor fatigue, and it's reflected in the results that we have. And we need about $20 billion to be able to meet the 1990 targets, and I think it's not there. So just one or two things that I wanted to mention is regarding diagnosis. There's a lot of improvement, including things around recency testing, self-testing, and so on. New developments, as I mentioned, better rollout of PrEP and so on. And as far as treatment, the U equal U through DTG and TLD rollout, but also more and more work being done on drug resistance so we can better understand the epidemic. And lastly, I just wanted to say something about the importance of political courage, the importance, not just commitment, but courage, the importance of putting the last mile first. They're looking at laws to follow up. The HIV disease model that I think Professor Katabira talked about maybe is an opportunity for us to learn about how this could be applied to other diseases. For example, political commitment, things like innovative finance, data-driven implementation, and then leveraging the regional economic communities, for example, the ECOWAS, the SADC, and the East African community. I do want to thank my colleagues that have helped me with this presentation. I want to particularly acknowledge the role of UNAIDS Ghana, who are hosting, who are in the country that's hosting this meeting. And just to leave you with some of the work that's being done in Uganda regarding ending HIV, again, looking at the last mile first, including reaching out men where they are safe through boxing, the sport of boxing. Thank you very much, and I appreciate your attention.